do that. So excited. Well, first of all, I'm Monica Grippo. I'm the founder of Rhea. I know, I think almost all of you, I have met, but for those who I am meeting for the first time, thank you so much for being here. Um, I am so honored to have Dr. Wade with us today. I wanted to share a little bit about how we know each other. So we've known each other since we were in grade school or junior high. So like 13, 12, 13 years old, which is wild. And we were besties in high school, and then lives took us in different paths. We reconnected in our late 20s and partied our butts off and traveled to Thailand for 2 weeks together, which was like one of the most memorable trips I've ever taken in my life. And now we're in this season of, 10 years, a decade later, where, we're a lot older, a lot wiser, I like to think. And we are moms together, and we both deeply care about making an impact in women's health. Dr. Wade has been working in this space for over a decade with patients, really focusing on fertility. Um, and I am very new to this space. But it's just so special that we can come together and partner together and really try to fulfill both of our shared missions. So thank you for being here. I'm so excited for you all to listen and learn from Dr. Wade.
Thanks for having me.
Yeah, so I wanted to just give a brief overview of, Dr. Wade's background and what she specializes in, and please feel free to chime in. But she has her doctorate in naturopathic medicine. She is based in Oregon, outside of Portland, and does in-person visits, but also does virtual consultations. And while she really does have patients across the spectrum and does not only treat females, she very much does focus on fertility work. And that's everything from preconception to working with people on their gut, postpartum care, and everything in between. And here's just a list of some of the conditions that she often sees when she's meeting with patients. And so, anything else you want to add about kind of your background and your practice? I'm curious, actually, like what percentage of your patients are coming to you because they're trying to conceive or struggling with fertility?
Yeah, at least 50%. My in practice, like my patients in Oregon, that come to see me in person, I would say probably closer to 70, 80%. Um, because there's so many naturopathic doctors in Portland. And so usually if people are coming to me there, it's really specifically because they want to work with me for that reason. And then my virtual clients, it really varies. Sometimes they find me on podcasts. I've talked about gut health or things like that. So that's another major area of specialty that I have. So, but it's still by and large, so a vast majority of my patients are coming to me for hormone related concerns or fertility.
Okay, awesome. Great. So speaking of, I just wanted to lay some groundwork and foundation and just hear from you. What is a naturopathic doctor?
Mhm. Yeah, so naturopathic doctor, we are licensed in, I think there's maybe 32 states now that recognize the naturopathic doctorate license. So it is a 4 or 5 year doctorate program where we have to pass board exams and licensing exams and maintain, our continuing education for our license. So a lot of times people will say, like, think we're a health consultant or something like that. Like we don't have a doctorate degree, but if somebody's calling themselves a naturopathic doctor and not just a naturopath, then they have to have had, that doctorate program and pass their board exams. But our education is more based in identifying root causes, learning the human physiology of why disease develops instead of just learning how to treat it. So we have a lot less focus on pharmacology, and a lot more focus on human anatomy and physiology and botanical medicine, homeopathic medicine, nutrition. So really learning to try to prevent disease instead of just treating it once it's there. But we do also learn pharmacology. I do have a license to prescribe in Oregon, medications if needed. but it's very much different in terms of how I use it very little. And I try to avoid those things personally, if I can, and try to address the root cause. But sometimes I will, use my license to prescribe for certain things. And, our appointments are much longer. I would say that's another big difference is that my initial intake with somebody is 90 minutes. My intake forms are 6 pages. So people often tell me that's the most extensive intake form I've ever filled out. How about my history? I'm really trying to go back in time, learn, as much as I can in that initial visit around the person's history, to make a plan moving forward versus, conventional medicine. Usually doctor's appointments are around 7 minutes where a doctor is actually with a patient. So there's a lot less opportunity for getting that comprehensive, holistic overview of the patient's history and being, an educator. Part of a lot of what I do is education with my patients around understanding what's happening in their body, understanding what I'm recommending. So I have a lot more time to do that, which really is what called me, to this profession because I felt very frustrated in my medical care when I was growing up in terms of how short and, how there wasn't really space for asking questions.
Thank you for that. Yeah, that was one of the craziest things that I just saw actually recently that OBs typically have 7 minutes to meet with patients. And it's true. I mean, there just isn't that deeper dive into all the things, right, that impact our health, our lifestyle, what we do for work, and our stress levels and everything. So that is a major difference. You did touch on some of the key similarities and differences. One other that I think stood out to me in just what I know from my history is the nutrition uh, education. There are doctors, OBs that have zero nutrition education,
Yep.
which is wild. But for a naturopathic doctor, are there a certain amount of hours that are required, or is it just more often part of their background?
Oh, yeah. I mean, I'm not, I would have to go look up the statistics on the actual amount of hours that we study nutrition, but it's a huge part of our education. And it's woven into every aspect of, our education versus, a medical doctor. A lot of medical schools don't have any nutrition programs at all. And sometimes it's like an elective or they'll do like 3 to 7 hours in the entire 4 year medical program. So yeah, that's a huge difference. And really important, I mean, what we eat is vastly impacts our body and our health. So it's a huge missing piece if we're not addressing nutrition.
Yeah, absolutely. Um, you talked a little bit about the consultation and intake. Can you speak a little bit to what happens after, right? So you have this 90-minute session where you're going through your history and really doing a deep dive and then what? What happens next typically?
Yeah, so sometimes patients will bring their lab work to me that they recently have, so we can go through that. And then if they are coming with no labs or very limited labs, usually I'm recommending basic blood work to start. So there's a pretty comprehensive list of labs that I run with most of my patients to look further into what might be going on with their health and making sure we're not missing anything big, major thyroid issues, low vitamin D, iron issues with iron and other nutrient depletions and checking blood sugar and their cardiovascular health and things of that nature. And then, if we're doing fertility work, I really like to use a Dutch test, which is a urine hormone test, where you collect your urine over a 24-hour period of time, and you get about a 16-page analysis around all of your sex hormones and your stress hormones. It also looks at your 24-hour cortisol and how you're metabolizing cortisol and what's happening with your cortisol overnight. So that is really helpful because stress, I ask about it, but it's so subjective, especially in today's days of age, I think, are all used to a certain degree of stress that's really unhealthy. So that's a really helpful tool that I use with my fertility patients often. So we might do some functional tests of that nature, looking at the vaginal or gut microbiome in more depth. it could really vary. Those are the most common tests that I run. And I also do a lot of food intolerance evaluation with my patients to help them really identify, a food group that might be inflaming their body. And I find that to be really helpful at addressing root cause inflammation and really turning around a lot of aspects of people's health. So we usually, based off the history and what we've uncovered in that 90 minutes, I'll make some recommendations around further testing. I will give usually some dietary recommendations, lifestyle recommendations, supplement recommendations, and then we meet 4 to 6 weeks later to check in and see how everybody's doing. And then, I don't have any minimum requirement of you have to set up a certain amount of visits or work with me for a certain amount of time. I like to just work with people with what they can afford and know what's possible for them with their schedules. But, anticipating at least like 3 visits if you want to establish care, I think is good because it's, we can't fix everything in one visit, of course. But I do find that 3 months is a really good time to turn things around if the patient's really invested and they're able to make all the recommended changes and implement, the things we discuss into their life. I see really great results within usually a 3, 6 month timeline. And that's where I'm usually, that's my goal is to turn things around at least like 75, 80% of the time in that time frame.
Okay, awesome. That's super helpful. And then the last piece on this is really around how do you work with patients' care teams, right? So most people coming to you probably have at least an OB. Maybe they see their primary regularly. Maybe they're going to already see a fertility clinic and have a reproductive endocrinologist. So how does that work when they're also seeing doctors and getting treated with, other people?
Yeah. Well, for my local patients, I do have some established relationships with OBs and fertility clinics in town, as well as, other GI doctors and things of that nature. So we do sometimes cross referrals, or we can hop on a call and discuss case. If the patient's comfortable with that, they can release their records, from their current providers and have them shared with me. That's the most common thing that people do is they sign a release of records with their current providers and they fax me all their records, or the patients can just directly upload them into my portal and I can review everything so that I have that comprehensive background. Yeah, so it's hard. It's hard to coordinate care amongst several providers. We're all busy, but sharing records is the most common way.
Okay, great. And just wanted to let everyone know if there are questions that come up as we're chatting, please feel free to chime in or drop them in the chat too, because this discussion is really guided by what Rhea members have already submitted as questions. But this is very much meant to be, an ask me anything type of vibe. So please feel free. Okay, great. So moving on. Let's talk about then optimizing fertility from just kind of an overall perspective. What, if we had to narrow them down, what are the top 2 or 3 things that you're like, everyone should really be doing this?
Yeah. The first thing that always comes to my mind is optimizing the gut microbiome. By chance, when I was starting my practice, I started working as a consultant with a gut microbiome company many, many years ago. And I'm so grateful, that I did that because it wasn't a passion of mine, the gut microbiome, but I really, really had a lot of respect for the founder of this company, Microbiome Labs. Karan Krishnan is this really world famous microbiologist who started this company many years ago. And I saw him speak at a conference, and I just was really floored with his ethics and what he had to say, and asked if I could get involved in the company. And through that, I've become a gut microbiome expert. I've researched for many years and wrote papers for them on varying topics around, the gut microbiome and things that I was interested in. So I would, look at the connections between endometriosis or PCOS or the vaginal microbiome or breastfeeding in the microbiome and write papers for them that they would share with their community. I've spoken with them for them at many conferences on varying topics related to the gut microbiome and brain health or skin health or hormones. And so it's really allowed me to kind of bridge the world, especially between hormones and the gut microbiome. And the gut really influences every organ system in our body. There's nothing it doesn't impact. So I think it has the biggest domino effect on, our overall health is if we are able to really work on our gut health and optimize our gut microbiome, we will see everything shift in the rest of our body. So that feels always number one for me. There is a pretty famous naturopathic doctor, Dr. Carrie Jones, who used to be the chief medical director at Dutch. And she says herself, like if you have to choose between a hormone test and a gut test, do the gut test first because that will impact the hormones. Um, and then the second thing would be really working on your nervous system, which is really hard. And I think people want to really fixate on the easier things like taking supplements, than really looking at things in their life that are really challenging. Particularly, I find relationships. Sometimes people are in relationships that are really stressful for them, and it's hard, to leave. I know from personal experience, hard relationships, jobs, that are really stressful. And of course, that's a really complicated subject. But if you are operating, at a pace that your nervous system is constantly feeling fried and burnt out, it's going to be really hard for your body to heal. And especially in this world and this topic we're talking about with fertility, for your body to feel like it's safe and it's at the right time to bring in a baby. So, nervous system work, stress management, there's so many different ways and options with that. And we do inherently live in kind of a stressful world. And so I think it always has to be kind of top of mind. Like, what are we doing every day to try to combat the stress of modern life? The third thing, um, let's just stick with those two. Those two are big ones, I would say, for hormones. Yeah.
Um, I know how passionate you are about the gut. And there's so much to learn there, and maybe that'll be like a good follow-up for us. But there is an amazing podcast. There might be some new ones too that you could share with us, but I'll drop some of those other resources and interviews that Dr. Wade has done on the gut microbiome specifically, because it is like a whole nother topic to unpack, and it really is foundational. Um, the answer to this question might be the same, but like with your patients that struggle to conceive and ultimately get pregnant, like what are you typically finding that they're changing? Like what are and obviously everyone's health is individualized, but can you kind of speak to, these are the common things that you're seeing?
Yeah. So, a lot of times people will change their diets when they're pregnant because, they're like, oh, now I feel really motivated. Once we become, I think, we become mothers the minute we conceive, not just when our baby is delivered. And so there is that, I think, primal drive to care for your child, right at conception. And so I see a lot of mothers wanting to, make changes to their diet. And it can be hard to do that, especially in first trimester when you don't feel well. Most first trimester parents want bagels and cream cheese, things that are just really settling to the stomach and not actually the most nutritious foods. So I think it's a good idea to do that before. I'm a big advocate of preconception work, really working on optimizing diet, laying down foundation before you get pregnant. And we can go into all the reasons why for that maybe later. But that diet changes are big on people, often want to know supplement recommendations like what should I be taking, for the health of myself and my baby during my pregnancy. Um, People have a lot of questions about coffee and, what things they can eat or not eat. So I often have, within the first week of somebody finding out they're pregnant, a check-in call with them to kind of go over all their questions that they have. People will often wonder about exercise. There's just so many different questions of what can I do? What's safe for my baby? That drive to kind of protect it kicks in really quick. So it's good and helpful, if you have the foresight, if you're planning to conceive and, have that kind of foresight to plan ahead. I'm a huge advocate of preconception work and trying to learn all this stuff before you conceive so that once it happens, you feel a little less anxious and you can just kind of focus on getting yourself comfortable in that first trimester and settling in.
Got it. And so really, if you're for the patients that come to you and they're like, maybe I've been trying for months, a lot of it is really that preconception work that you would recommend for everyone. So diet, lifestyle, potentially supplements. Is that fair to say that like usually when they do that foundational work, then they have success?
A lot of times, I mean, it's huge. Yeah, doing that foundational work is huge. Advanced reproductive technologies, ART, like IUI and IVF, and certain medications, they aren't doing anything to address root causes of infertility. They're trying to circumvent and get around why somebody is infertile. And so, regardless if somebody ends up conceiving through ART or naturally, doing the foundational work is going to improve the health of the mother, of the baby, of the pregnancy, of the child's health, even after they're born, even their grandchildren's health. So, doing the foundational work has immense payoffs, regardless if you're able to conceive naturally or not. But yeah, I mean, a lot of times, if they've already been trying for a while, we're really digging into the root causes of infertility and trying to figure out what the issue is and addressing that more acutely and specifically, which might look, a lot more specific versus just foundational things.
Got it. Okay, great. And then you mentioned coffee, but this question was really like there were just questions around like what are the top, myths or misconceptions around fertility. I mean, you see a lot of things on the internet. You get bombarded, I think, once you kind of go down the journey by like ads for teas and all the things that you should be trying, and it's overwhelming. Um, so maybe for this question, just hit on some of the top misconceptions that maybe people come to you and you're like, no, that's really not true or whatever. Or how to maybe like cut out some of the noise that exists on the internet.
Yeah. Well, I really don't like the word infertility because women are diagnosed as infertile. So if you're under the age of 35 and you've been trying for a year, you receive that diagnosis of infertility. If you're over 35, then it's only 6 month window before you receive that diagnosis. And infertility really implies that you're not able to conceive, and only really 2% plus or minus 1% of the population is truly infertile. So a big myth is that, that infertility is, that word, like somebody being diagnosed with infertility, it's not really true. It's just that they're in a period of subfertility. And at that moment, they might be infertile, but you can change that. It's a variable that is changeable for most people. And so, I think there's just a tremendous amount of research around, leaving hope for patients, and not kind of putting them in a box. And I think that term puts patients in a box and really kills a lot of hope. And that I think has profound effects psychologically on women. And so I encourage women to remember that despite your age, it just takes one egg. And so another thing, is I have a lot of women work with me in their 40s who are trying to conceive. And women come to me, in their early 30s and they're really worried about trying to conceive because they feel old. And I always I'm like smiling because to me, they're so young still. If like a 32-year-old's coming to me and she's worried about being too old trying to conceive, I'm like, wow, you have at least 10 fertile years ahead of you. That's a whole decade of fertility. And there's so much opportunity there, to shift anything that might be off and causing a period of subfertility now. So there's a lot of statistics around infertility, and it certainly does decline as we age because, of course, every month we're going through eggs, and every month we recruit a new cohort of eggs to mature, and then one becomes the dominant follicle and we ovulate it out, and we only have a finite number of eggs that we start with. So there, of course, is a decline in our ovarian reserve as we age, but there's something called biological aging and chronological aging. And while we cannot change our chronological age, we can change our biological age. Like how our cells are actually aging. And so a lot of the work that I'm doing is in efforts to reverse that. And so women will come in with, very low AMH, which is a marker of their ovarian reserve, and they will feel really not optimistic about their potential to conceive because of that number, or maybe their follicle stimulating hormone is really high, which can indicate poor, options with conceiving. And I have seen hundreds of times those numbers go in the direction we want them to move in. So FSH reversing and going down and AMH going up through the, work that we do together. And that's just clear confirmation that, our bodies can actually reverse biological age. We can actually become healthier even though time is moving forward based on how we're caring for ourselves. And so I think that is a big thing to voice in this space is that regardless of what your labs say or maybe what diagnosis you've received, it just takes one egg and there's always hope. There's usually hope, and so don't lose sight of that.
Thank you for that. Yeah, I struggle a lot with the word infertility, and I've been thinking about just like scrubbing it from from Rhea's website and our vocabulary. But yeah, I think that's a really great point. I think all too often we kind of are given that diagnosis if we can't conceive after 6 months or a year, depending on our age, and then even after losses. Um, it's it's almost like you are taught to believe that you are infertile when that is not the case, like medically even. So that's a really great point. Um, okay, moving on. We're about halfway through time, so I kind of want to speed things up a little bit. So I'm going to try to be a little bit choosy over some of the questions here. Um, I think, can you talk about some of the more common these two questions are kind of intertwined because we talk about lifestyle and natural health modalities. Like, what are the ones scientifically proven to treat some of these diagnoses, which you already kind of touched on, but can you be a little bit more specific when it comes to, people who have these common conditions or diagnoses, like this is what we're doing and it's actually making a difference.
Yeah. So, ovarian factor infertility is the most common cause for women. So sometimes women are not ovulating or they don't have good ovulation. They're not able to develop a good follicle that can, sustain a pregnancy. And so, a big reason for that currently is polycystic ovary syndrome, PCOS. It's one of the most common things I see in my practice. It's largely related to insulin resistant and blood sugar issues. And when people have high, blood sugar that's not well managed, it will drive up hormones like testosterone and DHEA. And women might start to experience things like male pattern hair growth or facial hair growth on their face or hair shedding. They will stop ovulating, so either having really long cycles or no period whatsoever. Obviously, if you're not ovulating, you can't get pregnant, so it's a big cause of infertility. And they might see, if they were to get an ultrasound, what's called like a string of pearls on the ultrasound. So a lot of small follicles, multiple cysts on the ovaries. And that's a big thing that I see now. Blood sugar is a big problem, as all metabolic diseases in this country. So that's one of the biggest things I see. And there's a lot of opportunity there to address the root cause. Conventionally, women are usually just put on metformin or given birth control when they have PCOS. But, I'm working with women, having them wear continual glucose monitors so that they can learn about their blood sugar and really learn how to manage it well. We use things like inositol and N-acetylcysteine, NAC, Vitex, which is chaste tree berry, often in my practice to help improve ovulation and get women ovulating again and improve the quality of their eggs. And inositol helps lower those androgens, testosterone and DHEA. So I see that all the time and treat it. Endometriosis is another big one. It takes an average of 9 years for a woman to receive a diagnosis of endometriosis. So that is largely missed in the conventional medical world. I can't even tell you how many times, I have helped women heal their relationship with their menstrual cycle. They'll come to me with a lifelong history of pain with menstruation, and I will help their bodies, reduce the inflammation in their bodies so that they don't have that painful, crampy period. And when we have those endometrial lesions, it kind of creates a toxic environment for the sperm. And so women will have infertility issues a lot with endometriosis due to inflammation and imbalance in hormones associated with that. And so there's a lot we can do to address core root causes of inflammation. Working on the gut is largely a big part of correcting both PCOS and endometriosis. And of course balancing hormones. So that is another big cause, and thyroid issues are another big one. A lot of women have hypothyroidism, and oftentimes the menstrual cycle can be affected, or women will stop ovulating when they're hypothyroid. And so we, use various things to support our adrenal glands with that is really important, making sure you're getting all the micronutrients that you need to support your thyroid, like zinc, selenium, iodine, and also working on your gut, because a lot of our actual thyroid hormones are converted in our gut to available thyroid hormones. So when we're thinking about thyroid disease, we have to address the gut, our adrenals, and micronutrients. Those are probably the top three that I see for women.
Awesome. And again, the gut comes up and we don't have the time to go into all of it, but if we do at the end, I have some specific questions for you, but we'll see if we get to them. Um, so, given a lot of the times when people go through initial testing with their OB and they have had maybe loss or just struggling to conceive, not just, I should not diminish that, but when things look normal and there's nothing that the OB can address, which are really those like top line tests, then you're sent to a fertility clinic. Like that's the next step. Usually it's like, okay, now explore doing assisted reproductive treatments. So what advice do you have for someone who's like how will I know if, going down the IVF or IUI route is right for me or the right next step or if
Yeah.
it's really necessary, right?
I don't think it should be the first next step. I mean, if the time and the willingness is there for the individual and their partner, if they're, trying to do this with a partner, instead of a sperm donor, if they're both willing to make changes in their diet and lifestyle and invest in, testing and supplements that will help them reverse whatever is at causing that and hindering their fertility, then I think that's the best route to go because it largely impacts the health of the pregnancy. It greatly reduces your risk of miscarriage. So if you get pregnant with ART, like IUI or IVF, but you haven't addressed certain root causes that could contribute to miscarriage, you might still lose the baby even after going through all of that. The health of the pregnancy, the health of the baby, again, with epigenetics and all we know about how, our health at the time of conception influences our grandchildren's health. There's so many reasons to do that work, before going to ART. Even if you decide that you want to go do ART, your chances are going to be greater. And Monica, I think you are the best example. I use you as a case study with my patients because you did all that before you did IVF and you got like an astronomical amount of eggs. So your chances of having a successful, IVF and egg retrieval are going to be so much greater if you do that foundational work beforehand. There's really cool data coming out around vaginal microbiome and how, if you have a dysbiotic, which means like not the right balance of microbes in your vaginal microbiome, your chances of IVF are going to be way less successful. And those women who have good, healthy vaginal flora have much greater IVF success rates. So I think it's such a big investment. It's such an emotional investment. It's very hard on the body. I think it's always worth doing that groundwork first. IUI, I am trained to do IUI, even though I don't offer it in my practice because my schedule just doesn't allow for, successful IUI practice. But IUI is most, beneficial for people who are having male factor infertility issues. So if the sperm are not motile, if they don't have good motility, or if there is very low morphology or very low count, they can wash the sperm and put it much closer, to where the egg is going to be released, so it doesn't have to travel. They can wash out all the wonky sperm, and so it's really good for individuals who have poor semen analysis, essentially, and the men, aren't willing or able to get the count or shape or swimming function improved. So IUI is usually, patients should know that if you're going to do IUI, you should plan to have at least three IUI transfer IUI sessions. It's usually not successful in the first round. And so, just kind of going into that and thinking of cost, that you probably are going to have to do two or three, before you might see a successful treatment with IUI.
Great, that's super helpful. And yes, although I did go on to do IVF, I tried my damn hardest not to. And, I did feel very lucky of how our first cycle went because I know that
You
that's
get 16 eggs or some, I mean,
well, the egg count was like in the 20s, but ultimately we ended up freezing 10 embryos, which is a huge number.
it's huge. That
Just
is huge.
having that like, you know,
Yeah.
safety net. And I mean, I did do a lot of work on everything to try to avoid it. But feel lucky that that was, the outcome that we had on the first go
Yeah.
around.
I have never in the history of my practice had a patient have 10 pass all the testing. So,
Woohoo! Well, I credit a lot, and for the record, Dr. Wade is not my doctor, but she has been there for me and helping me, consulting me when I'm just like, what's going on? I need help.
yeah, we
Okay, so
tried. We tried early on, and then we're like, we can't work together as friends.
it's a little too much. No.
Yeah.
Um, so okay, so there's a lot here. So we're going to go into labs and specifically because there's a lot of community members who have experienced loss and specifically recurrent loss. So what we're defining as two or more. That's not some practices, some doctors won't even like, you know, even do more extensive labs until you've had three or more losses and it's really hard to navigate. But for these purposes, so Dr. Wade shared a pretty comprehensive list of all the labs that she would recommend for someone who has experienced recurrent loss. And we don't have time to go into like what every single one of these are. I will do essentially like a handout or resource of all of this in one place, so everyone in the community will have access to that. So for the purposes of this, I just wanted to give you a chance to just talk kind of high level of like, what are we looking for, right? And why are like all of these hormone tests and everything, um, what are the specific call outs, I would say, that this goes a little bit deeper, right, than what you typically would get ordered from your primary or even your reproductive endocrinologist.
Yeah. Yeah. The one of the biggest reproductive endocrinology clinics in Portland invited me for lunch a couple months ago, and they then afterwards sent me their list of labs that they do preconception for people, and I was shocked at how minimal it was. So it's not very common, and they're great. I refer patients to them all the time. I think they're wonderful, but I think there's just a lot of gaps in conventional care with missing, again, these root causes. So thyroid, we've talked about, is really big. Miscarriage can often be caused by hypothyroidism, and there's still not a standard recommendation about testing thyroid in pregnancy, but it's really important in first trimester, like as soon as you find out that you're pregnant, to get a full thyroid panel done and make sure that your TSH is under 2.5. That reference range when you're not pregnant goes up to 4.5, even though that's not optimal to be really above 2.5, even when you're not pregnant. But when you're pregnant, it lowers to 2.5. So you really need to make sure your thyroid gland is optimal and that your thyroid's functioning well, because your baby is relying on your thyroid hormones. They take your T4, which is the hormone your thyroid produces, until about 20 weeks or something, until they can start making their own. So there's a much bigger stress on your thyroid when you're pregnant than when you're not. So that is a huge thing to look into before for infertility, because it impacts your hormones, and also for preventing miscarriage. Looking at blood sugar, we talked about PCOS and why that might be important. And then really important to look at those cycle day 3 labs. So a lot of doctors, especially if they don't focus in hormones, do not test these on the right day. In order for these levels to be accurate, in terms of how you're interpreting them, you really need to go on the third day of your flow, which is the first day is the first day of a full flow, not when you're spotting. So getting your FSH, LH, and estradiol tested. If your LH ratio is higher, like if your LH is higher than your FSH, that's a sign that you're not having good ovulation, and might not be developing a good follicle. And that can be, a problem. If your estrogen is too high or too low, you might not be building a good endometrial lining, and that can impact miscarriage if you don't have a good and right size. It could be too thick or too thin. Your AMH, we talked about briefly, that's your ovarian reserve. I don't get too hung up on that number because I see it move around all the time. So honestly, I just encourage women to do things that help support how their eggs are developing, as we're trying to help them conceive. Prolactin levels really important because when you're nursing, for example, if you nurse a child, you produce prolactin. It helps with milk letdown, and that's a lot of the reason why women don't get their period when they're nursing. So if you have a high prolactin level, which is really common, that could be impacting ovulation. So having that checked, DHA and testosterone are important for, DHA is really important for how your egg's developing, really important for that. And testosterone, if it's high, could be causing anovulation, and often is a cause of, PCOS. Sex hormone binding globulin kind of binds those sex hormones, so that that's too high. That could be a reason why you're low in some of the hormones. So we want to look at that. Your cholesterol is just good to look at your overall metabolic health. Your lipid panel, you also need enough cholesterol. So having low total cholesterol could, that all of our sex hormones are made from cholesterol. So we need to make sure we have enough good healthy fats to make healthy hormones. Iron panel, just wanting to optimize your, iron levels and things of that nature before you conceive, because again, a lot of women become anemic in pregnancy, and then comprehensive CBC is a complete blood count, also looking at anemia and, making sure you don't have any active infections and things of that nature.
Great. And there are, I think the next, let's see, the next
Yeah.
piece is really the imaging.
Yeah, so this is really important for, recurrent pregnancy loss. This is a little bit more specific, I would say, because if you've had two or more, miscarriages, then you really want to make sure you don't have a clotting disorder. And so this is like a list of labs that you can test for various clotting disorders. You could again, get an MRI or ultrasound, to have them measure kind of your endometrial lining and look at maybe what's going on with that. Some women have, again, endometriosis or something called adenomyosis. So assessment of that uterine cavity. Sometimes you'll do imaging. SIS is saline infused sonohystogram. And so they basically blow up your uterus like a balloon with saline and get better imaging of the inside. So sometimes there's polyps or things that could be impacting fertility or miscarriage, fibroids, hysteral salpingogam, the HSG is when they flush dye through your fallopian tubes to make sure that they're open and patent. So these are labs that, I do when women come to me with recurrent loss.
Okay, awesome. And I mean, a lot of people who are not working with a naturopath when are trying to advocate for themselves, and they're like, okay, I have this list, and maybe I'm going to go to my OB or my reproductive endocrinologist, and no, most people are not going to be able to explain exactly why they want it, but like, what would the words be that you would advise someone to use with their doctors to really push for clarity and just more,
Yeah.
I guess, ruling out, right,
Yeah.
through more
Well,
expensive lab.
now we have ChatGPT. So if you don't
Yes.
understand, if you don't understand why that you have this list, you could put like, why would I want to get this lab? Ask ChatGPT for fertility, and then you can rehearse or, try to learn and educate that. I also go through it in my course, Fertility Reclaimed, which we'll talk about later. But a good tip, for people who are working with providers who might be resistant to ordering a full panel of labs is to just really kindly say, if they deny your request, just would you mind please noting in my chart that you denied this request for these labs? And the key is kindness. You do not want to, come with aggression of any sort, or hostility. But if you just kindly say that, nobody wants to be responsible for missing something. So I've had a lot of patients have success with using that trick to then the provider's like, oh, okay, I'll actually run them. But a lot of providers have egos and they don't want to be told what to do. So I think that that's what I see a lot is that they're like, oh, my naturopath wants me to get these. And
Yeah.
certain providers might have preconceived notions about naturopathic medicine and if it's quackery or whatnot. And so they just it triggers them and they're like, I'm only going to run what I feel is necessary and don't ask me to do that. So, hopefully you can find a provider that's willing to work with you, to listen to you. It's not always the case, but that little trick can be helpful. And then, if you really are struggling to understand more, use ChatGPT. It's a great resource.
Love that. And I love that tip of asking them to mark that in your chart. That's a great takeaway. Um, I don't want to go into we just don't have time to go through all of this, but I think one thing to take away is that male factor infertility is about half of, it's half the issues. And so
About
oftentimes,
30, 30, 30, like female factor, male factor, and unexplained.
got it.
So,
Yeah.
mhm.
And so that's super helpful. And a lot of the times I think we see that these tests are just not done until you're like way down into the process where we should be really being proactive about male health. Is there anything else you want to touch on in terms of just overall um,
No, just that
testing?
it's really important, and to
Yeah.
encourage the men. I've only ever had one male patient like book the appointment for him and his partner to come see me for fertility, and he was really leading. It's always the woman leading, and sometimes getting their partners to come with, and so just encouraging, yeah, that conversation and coming together. I do a lot of consults with both partners, and also same-sex partners, if you're using sperm donors and things. So, both, it takes two to tango. It's really important to have both equations there and present, to have maximum results if possible.
Absolutely. Um, okay, these are some of the specific questions that came from our community, really advocating for answers. I think we touched on a lot of things that I think would help here, but um, when it comes to, having recurrent loss or just really trying to conceive and not, your labs come back normal, there's nothing glaringly wrong. Um, I love this question. How do I navigate being told it's just by chance when I've had four losses and my partner's labs are coming back normal? Like, what advice would you give to someone in this position?
Yeah. I mean, I had a couple that came to me once. I think they had four miscarriages in 5 months. And the woman was a PhD and she was super well read. She had read like every fertility book, every fertility paper. I mean, I think she honestly knew more than me. She, was on 35 different supplements. And so, it's very hard on the nervous system. You have that on your front page of your website. They say that, going through infertility is like experiencing a cancer diagnosis. It's a really hard thing. And it's a huge wave of emotions every month, lots of ups and downs. So it's hard to think straight. It's good to have an advocate. With her, I really just help pare down like what she really needed because not everybody needs all the things that could possibly help. I think you can definitely overdo it with supplements. I did food intolerance evaluation on them, and both of them removed their food intolerance. And the next time they got pregnant, it stuck, and she went on to have a healthy pregnancy. We also started progesterone. I can't remember if she was on progesterone with the first four, but um, I would not just be like, oh, it's just chance. Something is going on. If you're able to get pregnant, but you can't sustain a pregnancy, something is clearly going on and you want to figure out what and address it. So I would find a doctor who's willing to walk that path with you. I do think it's a very fine line. The second question around obsessing, it's very hard and it's much easier for me to sit here on this side of the table. I have two babies. I'm not trying to conceive and say this, but you really do need to use Google and these resources like in a smart way that's not racking your nervous system, like staying up late at night and Googling everything and going down these rabbit holes, I think can be really hard on our nervous system. And so that, sentiment of like, just stop stressing, go on vacation, and I'm sure you get pregnant, like that's not helpful for a lot of women to hear, but there is some validity to needing to safeguard our nervous system and really protect our adrenal glands because they really do highly impact our gut and our hormones, and our ability to feel safe and our wombs to feel safe, to bring in a child. And so I think, there's a really delicate balance of being proactive, but also really intentional with, trying to really create a safe space to welcome a child and for your nervous system to not be totally strung out through the process.
Great. That's super helpful. Um, There were a couple questions around blood sugar, insulin, and fertility. You already touched on it a little bit, and how you do recommend for your patients to do ongoing glucose monitoring, for example. Can you talk a little bit about just the overall connection and then how you've been helping patients kind of overcome some imbalances here?
Yeah. Blood sugar really affects our sleep. A lot of people who have unmanaged high blood sugar during the day, will have a very variable blood sugar throughout the night while they're sleeping. And so they might see if they're wearing like an Oura ring or a sleep tracker that their sleep quality is poor, or they might wake up frequently because their blood sugar is dropping or something of that nature. So, sleep is a huge foundational piece of our overall health. If we're not getting good sleep, it's going to be really hard for our adrenal gland function, which produce our DHEA, which is really important for fertility and egg development. And our circadian rhythm, like, for our thyroid and things like that, it's connected to all of those pieces of fertility. So, safeguarding our sleep, making sure we're getting 7 to 9 hours, good quality sleep, sleeping through the night, uninterrupted. Um, you don't have to be pre-diabetic or have diabetes to have blood sugar issues. A lot of people, I always run a fasting insulin because a lot of people's fasting insulin is above 5, and that's kind of the level I want to see it under. And when they wear a continuous glucose monitor, they see that, their blood sugar is spiking pretty high, after many different meals that they eat. So that's just a great tool for accountability and to really learn your body and see what you're eating and how it's impacting your blood sugar throughout the day. It's really associated with PCOS, which is one of the leading causes of amenorrhea, not having ovulation or long cycles and having disrupted hormones. So for that piece alone, it's also very important. And yeah, I think one of the best things one of the best tools we have nowadays is using continual glucose monitoring. You can just wear a sensor for like 2 weeks or a month and gain a lot of valuable information about your blood sugar and how to optimize it. There's definitely supplements that can help, like berberine and inositol, lowering your blood sugar, but there's no, replacement for a good diet. So really just understanding how to eat well, for, balancing blood sugar is important. And a lot of that is the right combination of, fat and protein with fiber, to balance your blood sugar.
Great. That's super helpful. And we'd love to get recommendations for the monitors,
Yes, we can do
so
that.
people
Send
can,
out a resource link.
yeah, perfect. This is a biggie, and I know we only have 7 minutes or 3 minutes, sorry. Um, but you touched on the vaginal microbiome a little bit. You actually told me a stat the last time we saw each other when for the women who have had recurrent pregnancy loss or maybe just miscarriage, they had like a very high percentage had
Right.
some sort of dysbiosis.
Mhm.
Can you speak to that
Yeah.
connection?
Sure. Yeah. One of my fertility mentors, Dr. Jacqueline Chassis, she's now the head of Dutch. She presented a study last year, in Chicago at a conference I was at, saying that, 90% of individuals who didn't have successful IVF, that when they were treated for vaginitis, like vaginal infections, they went on to have a successful pregnancy. after treatment. So yeah, that really got my brain spinning around the vaginal microbiome. And then Microbiome Labs, the lab that runs the stool test that I love to use and that I've worked as a consultant for many years. They have a vaginal microbiome test that I've been doing consults with for the last maybe 6 months. A lot more providers, they recently lowered the price of the test, so it's much more affordable now than it was before. And so a lot of the providers are using it. And so I'm starting to do consults with other doctors and helping them understand their patients' results. So I see a good amount of these every week, probably like 5 a week of other doctors. And a lot of people, I mean, it might just be that they're having recurrent BV or candida, and that's why they're running the vaginal microbiome test. But it's definitely more common to see dysbiotic, imbalanced vaginal flora than healthy vaginal flora. And the reason that affects infertility is that, when you have the wrong type of microbes in your vaginal flora, it changes the pH. And that vaginal pH, if it's too high, is not a good environment for sperm. So it can hinder their ability to swim, their motility. It can hinder fertilization. We know that women who have recurrent BV, for example, have higher risk of infertility, and that's actually a really common issue when women have like gray, fishy discharge, irritation. It's a common, imbalance in the vaginal flora. There's certain microbes that make women more susceptible to BV infections. It also increases the inflammatory response in the body overall, and that can affect our cervical mucus production. And cervical mucus is the fuel for sperm, and it what feeds them and decapitates misshapen sperm and helps the sperm get to the egg. So we need to have good fertile cervical mucus to conceive. And it also impacts the uterine lining. So when we're thinking about the endometrium, which is, where the egg implants, in the home for our embryo, we really need to make sure that vaginal, they're all the microbiomes are connected, but the gut microbiome influences the vaginal microbiome, and the vaginal microbiome influences the uterine microbiome. And there's, some really just cool research emerging now with a link to PCOS, and lots because there's so much money in ART, assisted reproductive technologies. We have the bulk of the research on the vaginal microbiome is with IVF, and they're, just across the board, all the studies are showing when women have healthy vaginal flora, they have more successful IVF rates versus when they have dysbiotic vaginal flora, they have, less success. So really, really good, solid research on that area. And if you're somebody who's trying, planning to do IVF, or if you struggle with infertility and you haven't assessed your vaginal microbiome, I would highly recommend doing that and working on it.
Great. So the answer is very important. And we're just starting to finally like do the research and learn about it. Finally, there's some attention. Um, okay, awesome. I know we're at time. And so I just want to check really quick. It doesn't look like there were any questions, but I do want to just highlight that we're really excited to bring Dr. Wade's Fertility Reclaimed course into Rhea. She's gotten a tremendous amount of positive feedback from people who have taken this self-guided 5 module course, and it's really for anyone who's whether they're trying to conceive or get prepared for IVF and just like fully be empowered and learn about hormone health and everything related to fertility. So we hope to get that live next week with a special discount for the Rhea community. So that's really awesome, and we're really thankful for that. Um, Dr. Wade's information is in our resource section. So you can find her website, her Instagram there. I can always connect people with her as well if you're interested in working with her directly. But there's just so much information that we are just scratching the surface in an hour. And so I'm really excited to just follow up with some of the resources we talked about, the lab work, just so that people have more direct access to some of the things that you've been working on with your patients. Um, Thank you so much. This hour flew by. There's just so much to cover. We would love to have you again, but I'm so happy that you joined us. Thank you for everyone who took their time to be here, and we'll make this available to everybody in the Rhea community.
Yes, thank you so much. I'm so grateful that you created this community. It's so needed, and it's just so beautiful that our work as adults is weaving together in such a synchronous way. And yeah, I mean, having a place where people can go to, talk to other women going through this and get free resources is such a gift, to this space. And so thank you, Monica, so much. And it's an honor to be here, and I'd love to come back.
Thank you so much. Have a wonderful rest of your day and week.